In this lecture, we will begin to discuss some common adolescent diagnoses. I've tried to highlight some of the changes for these disorders between the DSM-4 and the DSM-5, and I've also included updated statistical and demographic information that I hope will be more meaningful and relevant for us. When we think about working with teens, we probably think about the trouble that they must have gotten into that brought them to see us. This attitude is indicative of the notion of disruptive behavior disorders. Usually, these are disorders that present challenges for those around the teen. They are likely to begin earlier than adolescence, but they are more apparent now as the teen has increased capacity for aggressive and sexualized behavior. Here I've included a graphic that gives us a snapshot of the prevalence of ADHD in the United States. Disruptive behaviors have long been discussed and classified under the heading of attention deficit and hyperactivity disorder. As you all know, the main issues for individuals with this disorder include short attention spans, difficulties with impulsive behavior, and pervasive restlessness. This is a fairly common presentation. There's some evidence of heritability with ADHD, but there's also evidence that environmental toxins may be related. We know that social factors influence the manifestation of ADHD. If a child has a history of abuse, if there have not been consistent discipline strategies, or if the child's unique learning needs are not met, then ADHD may be suspected. Unfortunately, this diagnosis has been overused, and some believe that medicating children for ADHD is just a substitute for parenting. Here I've included a bit about the differences between the DSM-4 and the DSM-5. The primary difference that I saw upon first glance was the addition of a severity specifier. In class, we'll talk more specifically about this. Whenever you think about beginning to work with a teen who presents with symptoms of ADHD, then you want to first identify what those symptoms are, how they are problematic, and where they are problematic. Along the way, pay attention to any indicators of depression or anxiety. After you talk with the client, then you may go back and gather additional information from the parents. This conversation will look a lot like the parental interview that we described earlier this quarter. As you remember, there are certain assessment tools that you are qualified to use and some that are beyond your training. One of the most common assessment tools used with children and adolescents is the Conners. Your degree in education means that you are qualified to administer this set of assessments. I've hyperlinked the web page here. Click on the green text on this slide for further information. ADHD is often seen alongside other psychological difficulties. I can't help but wonder about the impact of cultural factors on the presentation of these issues during childhood and adolescence. I'd be interested in hearing your experiences with ADHD. I have 2 family members that have been diagnosed with this disorder, and I imagine that some of you all have personal experiences too. Many times, treatment for ADHD is reduced to only medication. You've had a class in psychopharmacology, so I won't discuss this in detail, but I did want to offer current information on what pharmaceutical treatments are available for ADHD. If you work with children and adolescents, I would encourage you to become familiar with these drugs. In addition to understanding medications when working with adolescents who have ADHD, you should expect to be met with some resistance. Remember, it is the teenager's job to question authority. This includes you. Don't let yourself get sucked into a power struggle. It won't help the therapeutic relationship. Pay attention to the indicators of low self-esteem with your client population. Chances are good that these clients have already experienced failures in different areas of functioning. When you are working with teens that have ADHD, it will be important to build a relationship with the parents as well. Set some ground rules before any family sessions you offer and help family members deconstruct their attitudes and beliefs about their child's struggles. Also, whenever you are working with adolescents that have ADHD, remember that psychostimulants have street value and they are often abused by teens. Be sure that you have an ROI for medication prescribers so that you can collaborate regarding any observations you might have regarding medication compliance. Finally, remember that there may be severe behavioral problems associated with ADHD. Be aware that there is some link, between ADHD and antisocial personality disorder. In addition to ADHD, the chapter authors discussed oppositional defiant disorder and conduct disorder. Here I've highlighted the differences that I saw between the DSM-4 and the DSM-5 regarding these. Again, the differences are subtle and have more to do with how the separate disorders are classified in the manual rather than any qualitative changes in criteria for diagnosis. These disorders often appear before adolescence, but can become incredibly problematic during this time as teens begin to experiment with risk-taking behaviors. Locke, your chapter author, stated that, taken together, a variety of possible pathways lead to a teenager's developing conduct disorder. A genetic vulnerability, compounded by an abusive and neglectful upbringing, with few models for coping with stress other than through violence and substance abuse, combined with a psychological unwillingness to manage these stresses in other ways, converge in the teenager with conduct disorder. Treating teens with severe behavioral problems will require patience, hope, and perseverance. This is not easy work by any stretch. During my music therapy years, I did a rotation at a juvenile facility. I had a group of about 6 guys that I worked with for several months. I'll use stories from this experience whenever we talk about using music with teens. But what I'll say now is that having a plan and having clear boundaries are critical components to treatment success. I appreciate the chapter author's advice regarding low street value drugs. While you'll not be in a position to prescribe, you will be in a position to work with a prescriber and offer your professional opinions. I would keep this one in mind. There are a number of approaches and strategies that you could use when working with teens with severe behavioral disorders. These are highlighted here. A lot of the work that you do in different agencies will be prescribed by the agency. I know students that go into different situations and they learn particular behavior modification plans and strategies for working with teens. One thing I would encourage you to do is pay attention to your surroundings and maintain your own personal boundaries. Dress professionally and don't expect that you will cure anyone. Set realistic goals, which will provide opportunities for the client to experience success. In this particular chapter, I took a great deal of liberty with the format of the PowerPoint in this lecture, and I believe that drug and alcohol treatment has changed significantly over the last 20 years. I want you to have at least a cursory understanding of how substance abuse is approached today. To begin, I found a graphic depicting recent trends in underage drinking in Washington state. As you can see, drinking is a pervasive problem for youth in our state. I hyperlinked some information from the Washington State Liquor Control Board for you regarding state law. Click on the green text here for more information. This area of revision in the new DSM had received a lot of publicity. There have been significant changes to the way that substance use is considered. Criteria have been altered and the thresholds of severity have been reformatted. We can talk about this more in class if you'd like to. I'll try to remember to bring both the DSM-4TR and the DSM-5 so we can compare. When we think about the pervasiveness of substance use disorders, we know that there are heritable traits to consider. There are a number of theories about the relationships between substance use and mental health, and as you begin your professional work, you'll have opportunities to learn about these in depth depending upon where you work and the treatment approaches that are used there. For teens, using substances is often a result of psychological factors such as a need to fit in, a need to rebel, a need to be different, low self-esteem, depression, a need to manage feelings, a response to abuse or neglect, and so on. What will be important for you to remember is to always assess the client's reality and what purpose the behavior serves for him or her. In addition to the internal psychological factors that can contribute to the development of a substance use disorder, sociological factors such as SES, school performance, legal problems, and risk-taking behaviors can also contribute to the development of a substance use disorder. Family factors can strongly influence development of substance use disorders as well. The ways in which parents educate their children and talk about alcohol use is a strong predictor of future substance use. Additionally, children and teens will model behavior after their parents. Finally, there are neurochemical theories that speak to the development of addiction in the brain. It's important to consider the genetic makeup of the individual and how that is being impacted by all the different psychological, social, and familial factors that can influence addiction. I know you guys had a class in addiction, so I'm only highlighting concepts here. According to Powers and Matano, your chapter authors, the process of addiction moves from normal experimental behavior to occasional use in social situations. Beyond that, an individual might start to regularly use a substance, and this is where a conflict with the family might surface first. Finally, when the adolescent focuses primarily on acquiring and using a substance, then we would classify that person as dependent. Whenever you think about screening and evaluation for substance use, there will most likely be a portion of every client's individual intake that considers these behaviors. In my experiences, I've often done an initial assessment of substance use. If problematic use is present, then I would refer that person to an additional assessment with a chemical dependency professional, or CDP. Most screenings for substance use will include the general information listed here, as well as a mental status exam. Working with teens who have substance use disorders will require a thorough explanation of the limits to confidentiality and your legal responsibilities. Please remember that if your teenage client tells you he has smoked a joint, that information is protected. You are not allowed to tell his parents. Again, know the state laws regarding confidentiality and make sure that your clients and their parents know them too. I would encourage you to be over-diligent in your discussions of confidentiality with teens and their parents. In order for treatment to be successful, trust must be established. We're not even going to attempt to discuss all of the different treatment models for working with substance use disorders. Right now, there are more than 200 evidence-based treatments supported by federal agencies for working with substance use in teens and young adults. Powers and Matano offered a number of proposed guidelines that I've included here. I'm not sure that I agree with all of these, and I wonder what your thoughts are. We might find time to talk about these in class next week. Here, I've hyperlinked information for you from the American Society of Addictive Medicine regarding current treatment levels of care. The information in your text is a bit dated in this regard. Be aware that agencies will have strict guidelines and policies regarding levels of care. Additionally, you may need to pursue an additional certification as a CDP if you are interested in working with substance use disorders, as that designation is often a requirement for employment in those positions. Finally, the authors discussed aftercare for substance use disorders. What stands out to me here is that aftercare can help teens as they move back into peer groups following treatment. Remember that change is superficial at first, and a good amount of support will be needed. Another word regarding outcomes. I think that outcomes should be directly tied to assessment and treatment planning. During the treatment planning phase, imagine what successful treatment will look like for each client and determine what factors will be used to judge the success of treatment. All right, that's it for our introduction to working with adolescents. Next week in class, I'd like to spend some time exploring Washington's specific issues regarding substance use in teens, especially since the new marijuana laws. I'd like to introduce music therapy and creative arts as therapy in your work with adolescents, and then I'd like to introduce our new client 10 years after the first treatment episode. We will work with the client on some of the current issues that have surfaced as the client moves into high school. See you soon.